Hello, everyone. Welcome to another edition of Newton-Wellesley Medical Group Lunch and Learn. We are really excited to bring back Dr. Tomczyk. She's going to be talking to us today about lumps and bumps on this glorious Thursday afternoon. Dr. Tomczyk, thanks for coming. Next slide, please. I want to tease our upcoming Lunch and Learns. Next week, we're going to have a talk about evaluation of inguinal pain. It's all about the history and physical exam by Dr. Nora Fullington. And then the following week, Kavita Sitharaman's coming back to talk to us about continuous glucose monitoring. Just a reminder, our older talks are out there. They're archived on YouTube, Newton-Wellesley Medical Group, as well as linked on our website on our intranet, www.nwh.org/intranet. Next slide, please. Just want to remind folks about our orthopedic walk-in as the weather gets nicer and people are out there in the afternoons and evenings on the ball fields. We are open Monday through Friday, 8 to 8, orthopedic walk-in. Any injuries we can handle there. We have x-ray right on site that is open at the same hours, as well as casting, a nice casting room and braces. We're also open Saturday and Sunday. That's 7 days a week. And that's a walk-in center, although the phone number is there if you want to make an appointment for your patients. Next slide. And here's some of the minor injuries that we will see there. Next. So I want to remind folks about 2 surveys that are ongoing. I know how everyone loves to fill out surveys. It seems like during COVID, we got a break for surveys, but this is a really important survey for me, and I think for all of you. This is our Burnout Survey. This is a survey that actually, when as analyzed, this is what gets us our grants to do a lot of the things that we do that help us save from burnout and increase the joy of medicine. All the dinner programs that we did before COVID, our call program for the PCPs, it all started with these programs. This Burnout Survey also came with a chance to win an Apple Watch. And in fact, at our RSO, we have won 38 of those Apple Watches. So it's definitely a real thing that happens, and there's still time to fill it out. Please take the time to fill it out. It should come to your box every Monday. So if you haven't filled it out and you're getting this on Monday, please take the time. I promise it'll be less than 15 minutes of your time and well worth it. Next slide. And just to remind folks about our physician and APP wellness programs that are continuing to be ongoing as funding is whittling down for these. Our Peloton 1-year free membership, all you need to do is sign up for the app. You don't need a bike or a tread. You can go ahead and you can sign up for that and we will reimburse you for a full year. So no obligation needed whatsoever. Physician Care Concierge program is a referral program where you can ask them anything you need or anything you want. Gifts for your spouse, how to set up a great party, how to get someone to grouch your bathtub, all that will be there. They'll send you 3 or 4 different recommendations. That's all free. Please sign up for that. Of course, we have our weekly virtual meditation classes, our virtual yoga class, and online coaching and physical training with Daniel Destin and his staff at the Shipley Fitness Center. Next slide. And this is Hospital and Nurses Week at Newton-Wellesley Hospital. So we have chosen a live ride on Peloton this weekend on Saturday morning. They're continuing to give away all this free food. Today, there's free ice cream in the cafeteria if you're on campus, by the way. And so we figured at the end of the week, we'd want to burn some of those calories on our hospital Peloton ride. This week, we have chosen a 30-minute rock ride with Sam Yo. That's at Saturday morning at 8:30. Please feel free to jump on that ride, either live or archived, and make sure you're riding with the hashtag NWHstrong. We really want everyone, as many people on that as possible to show our community. Next slide. And I'll turn it over to Dr. Tomczyk.
Awesome, thank you so much. It's nice to be back. I gave a lecture probably about 5 months ago now when I first started and joined our community at a fellowship. I'm a plastic surgeon. I do all bread and butter plastic surgery. And I've been working with our surgical clinic and our team upstairs in Green 563 to start a real lumps and bumps clinic. This really kind of was born out of request from our primary care physicians wanting a place that they could send patients. So I just want to go over a little bit about what it is and some common things I see and give you guys an opportunity if there's any questions. And like Dr. Snyder said, you should definitely go get your free ice cream today. I had mine before this, so I'm feeling really good. So really, what is this? It's a clinic that's devoted to benign and malignant skin and soft tissue things. It can really be almost anything. I try, a lot of it is stuff I can do alone in the clinic. I can do in the procedure room, whether it's a lipoma or a cyst or some small skin cancers that I can address. You know, I see patients as a consult, and then we book them for their procedure, which are typically done on Monday afternoons in my clinic. Patients love it because they can come in and drive themselves and drive home the same day. And not have anesthesia. Obviously, if needed, I will do things in the operating room, and I can go into a little bit more about that on future slides. Most of the things that I'm doing in this clinic are insurance-based cases, but of course there's some cosmetic things I'm happy to see and do, which I would kind of mesh into this clinic. So how do you send patients to us? You've got a patient that's in your primary care practice that you've been following for some time, and they have this growing mass or this bothersome lesion or something that just doesn't seem right. We are working to create a direct link through Epic so that you can refer them. So if you go into your Epic and you hit referral for a Newton-Wellesley plastic surgery, my name pops up as one of those. And within that, there's lots of options for why you're sending those patients to me. Right now, one of them says like cyst/lesion or something like that. You can click on that. They are building out the part that actually will say lumps and bumps clinic, and that's going to show up. So you just click on that and they get sent right to me. You are also always welcome to just email or Epic message me. That helps and works all the time. I get messages from a lot of you regularly, and it's really nice because it's kind of a little personal heads up about a particular patient, and sometimes gives me a little bit more background. So you're always welcome to do that. And of course, you could just call us. This is the number for my admin, Jane, who's a rock star. And so you can always just call us directly to sneak somebody in. These appointments don't take very long, especially for the initial consultation. So I try to sneak them in a really timely fashion. And then we coordinate the procedure based on the patient's schedule. So what kinds of things can you send to me? Honestly, anything. And if you have a question about it, just call me first or message me and we can talk about it, especially if you're wondering, should a patient have imaging first? Oftentimes I do not require any imaging of masses, but if they're in an unusual spot or there's something that's concerning you, if we can kind of make a plan to get some imaging ahead of time, it saves my time. It also helps the patient, I think, so that we're making sure we're doing the right thing and they're seeing the right person just in case it's not me. I commonly see lipomas, cysts, different skin cancers. I can do a lot of scar revisions in my clinic, torn earlobes or stretched out earlobes. That's a really common thing. That's more cosmetic, but again, I would kind of include that all within this clinic because they're just my little procedures that are easy to do. And if you have patients that are asking about it, please feel free to send them my way. So I thought we'd go over just a few very common pathologies that I see a lot. I'm sure I'll see all the time. I know you know all of this stuff, but I thought I could kind of give you my perspective on when I see these patients and what I'm telling them. So lipomas is probably one of the most frequent things I see in this clinic. As you all know, these are totally benign fatty tumors. They tend to be really slow growing, and you can find them anywhere on the body. They don't have to be excised, but oftentimes, obviously, when the patient comes to see me, it's because they're interested in having them excised. And it's because maybe they're growing. I see a lot on women where they rub where their bra hits, whether it's like on their shoulders or underneath their breast, or patients with many lipomas on their extremities, and they're just, unsightly and bothersome. Again, most lipomas I will excise in my clinic. The caveat is my personal preference is for large lipomas on the back. I like to do them in the operating room because I find the ones on the back tend to be more frequently intramuscular. And so it takes a little bit more to get them out, a little bit higher risk of bleeding, especially when they're very large. It's hard to have good anesthesia of that area with local because obviously there's a max amount of local I can put in. So by doing it in the operating room, I just have anesthesia put an IV in and give them a little sedation so they're kind of sleepy and don't feel the injection. And then I have a little bit more controlled setting to take out those larger lipomas. Or I had a guy recently who had like 3 big ones on his back and about 14 on his arms. And I was able to do them all at once in the operating room, which I would have been very limited in the clinic. So that worked out really well. And patients in general are really on board with that. I think they like that they don't need a breathing tube, but it is a little bit more of a commitment. So I like to kind of be upfront about that early on. In terms of cysts, epidermal inclusion cysts, also known as sebaceous cysts or epidermoid cysts, most common cyst of the skin. This picture is like a very obvious one. You can see that central almost blackhead. Because as you know, these connect to the outside world, and that's what happens, right? The dead skin cells and hair get trapped underneath the skin and it forms this cyst. The risk is that they can get infected. And I'm sure you guys have seen a lot of these patients come, for an urgent visit that day, or someone's coming to you for a follow-up after being seen in a walk-in clinic. And unfortunately, when they're infected, it's not a great time for them to come see me to get it excised, because it's really hard to appropriately excise them. The goal when you're taking out a cyst is to make sure you're getting that entire cyst wall. Otherwise, they'll just come back. It's funny because all of the patients that come in with these bring up that show Dr. Pimple Popper, and they think they're geniuses and like know everything about it. And they're like, oh yeah, they did this on Dr. Pimple Popper. It like makes me cringe, because trying to just like erupt one of these is the opposite thing you want to do. The goal is to cut out a piece of the skin in an elliptical pattern overlying that skin, that puncta, that opening to the outside world, taking out that piece of skin and the entire cyst with its entire wall. And if you can do it in one specimen without rupturing it, you're more certain you've gotten the whole thing out, and that's the goal. I will happily see infected ones when they're acutely infected. I do it all the time, especially if it's in a sensitive area and people are not comfortable INDing it. My typical approach for these are, if it's really painful and really big, I will incise it and drain it and pack it with a wick, and I start them on some antibiotics. I let them change the wick for a few days, and then the goal is to let it close back up and cool off. And then I bring them back in about 2 to 3 weeks when things have settled down for a formal excision of the remainder of that cyst wall, so that I can make sure I've gotten the whole thing out. And then ultimately have a smaller scar, because when they're really big and inflamed, as you can imagine, you need a bigger scar overlying it. In terms of some skin cancers, again, this is a very typical appearance of a basal cell, which is the most common form of skin cancer. It's that kind of pearly appearance with the little telangiectasias. Obviously, I'm not a dermatologist. I do not have a dermatoscope, but certain places it's quite easy for me to remove these and get a nice margin. Again, I do most of these in the office. I can even, depending on the size, excise it and do a full thickness skin graft if they don't have enough tissue locally to close it. I can do all of that in the clinic. Depending on the patient's needs, I will do it in the operating room if it's on their face and requiring a little bit more, or they're just super anxious. But in general, it's nice to do these in the clinic. And squamous cell carcinoma, which is the second most common form of skin cancer. These can look really different. This is the very common warty appearance of one. The other common one is that very heaped up edge with an open wound in the center. The problem with basal cells and squamous cells is they don't typically kill you. They don't typically cause a lot of problems, but they can become massive wounds if you don't treat them. And so that's where it kind of comes down to, depending on what the patient's comorbidities are, it's nice to just address them early on so that it doesn't become a bigger issue. And squamous cell carcinomas can actually be quite painful for patients. So it's nice to address them when you can. Normally when I see all these patients in clinic, I close them in multiple layers. I use a monocryl deep, and then I use nylon sutures on the skin, and then they come back a week or two later, depending on the location, to have them removed. Typically not a lot of downtime for these things. I let them shower right away, minimal wound care because you don't really need much. I put a dressing on that first day, and then the next day they can take it off. I always say you can put a Band-Aid on it if you want. And I think that makes a lot of patients feel more comfortable, or a little Neosporin, and that's it. So again, low maintenance, not a lot of downtime depending on the location and the size. Obviously for like large lipomas, that's a different story, but I think that's really nice. So just to summarize this stuff, you know, if you have a question about something or you're just wondering if it should even come off or what it is, just reach out. I'm always happy to answer questions. Again, like the Epic messaging system is amazing. You can always put pictures in there as well, which is super helpful. This group, this clinic itself is expanding as we bring more physicians into this awesome group. There's a general surgeon that's starting in the fall who's also probably going to be doing these. So availability and access to this is just going to keep growing to hopefully make it easier for all of our patients so they're not waiting. And the goal really is just to make this easier for everybody. So you know where you can send patients, make it a streamlined process, and have the turnaround time not be too bad. So thank you.
Thanks, Ellie, for that breeze through. I have a couple of questions. If you guys have any questions, you can throw them in the chat box. I wanted to get back to the lipomas because it's something we see a lot in the office as primary care providers or other providers. And a lot of times it's obviously easy to determine whether it's a lipoma, but sometimes it's not so easy. And the location can be sensitive, especially if it's in the neck. I found it's hard to tell the difference between the lymph node and a lipoma. Patients are not usually the greatest historians about whether it's growing or anything to that effect. So tests of choice, should we send for you first? Your finger's better than an ultrasound, or should we do the ultrasound first? What would be your preference?
So for me in general, masses of the neck, I do image, especially because I would still do something on the neck in clinic, depending on the size. I like to make sure I know what I'm getting into. So I do tend to ultrasound those. So it's fine if you're not sure, you can send it to me first. I can see them and send them for an ultrasound. If they have an ultrasound first, it just skips a little step on my end. But either way, I think things on the neck, I do tend to ultrasound first. You know, back of the scalp, that's different. I did actually have like a younger patient, a child that had a lipoma and then a second mass, and the second mass, I took out both, and the second one was a lymph node. And it felt like a lipoma, but when I was doing it, I was like, wow, it actually, when I took it, I was like, oh, this is clearly a lymph node, and it was quite enlarged, just a reaction of like a reacting lymph node. But it was causing a lot of alopecia, interestingly enough.
The mass itself.
The lymph node, like overlying
yeah.
that lymph node, yeah.
And then, so there's always this fear that, you know, as a primary care doc, I'm going to cut into a lipoma and you're going to end up with something that looks a lot different. Happened to me once in my career. It turned out to be a liposarcoma. Fear of that at all? I mean, any hints or anything to that effect or no?
It's always a fear of mine. I always tell patients, you know, I send everything to pathology because even though I'm pretty sure this is what it is, nothing is certain in life. And I always like to make sure we're doing the right thing. So when I plan my incisions, I try to keep that in mind if something further needs to be done, especially on the extremities, doing a transverse incision, because that's the standard if you're not sure if something is a cancer or not. But if you know, if something doesn't feel quite right, it's maybe a little firm in places, but I agree, you know, then maybe I would do some kind of imaging ahead of time. But I mean, you still need a tissue diagnosis. So I still would proceed with excising it with the caveat that it could be something we don't expect. And then we will address that. Yeah, I've had one this year, and luckily I had chosen to do it in the operating room. And it was so interesting because it ended up being a old hematoma cavity that had completely like formed a wall, like a seroma wall, and it looked odd. We thought it was a lipoma, but it was just so odd. And I called in a general surgery colleague to come help me because I said, you know, it's just really weird. I don't want to get into something I'm not that I can't fix. And interestingly enough, when we got to the base of it, you could feel a fractured rib. The guy had broken a rib, and when I talked to him afterwards, he's like, I told the people in my facility I did something. And, you know, it just, thank goodness I was doing that in the operating room. And I had colleagues nearby just to make sure, you know, but it's going to happen. And I think feeling like you can call for help or just do the safe thing, because alternatively, if someone wasn't available, I had said I might just close them up and get some new imaging and figure this out.
Sure. I don't see any other questions about this, Ellie. I do think I wanted to take a minute to talk about your breast surgery practice, because I do think it's a big part of your practice, and I know you gave us the talk before, and some folks on the call might have missed it. One of
Sure.
the things that at least I see a lot in my practice is the upper back pain, and women
Mhm.
requesting mammoplasty. I know that's a specialty of yours. I want to make sure folks on
Sure.
the phone know it is. And I know there are insurance kind of hookups and things. Are there stuff that we could do as primary care docs when we're
Yeah,
seeing these patients before they see you to make your life
absolutely.
easier and make their life easier to get it approved?
Absolutely. That's a great question. So I do a lot of reduction mammoplasty. It's actually one of my, even though it's a ton of work, it's one of my all-time favorite surgeries because it actually has the highest patient satisfaction in all of plastic surgery procedures. And I think it can be really life-changing, no matter the age of the patient, really young versus old. There are some kind of standardized check boxes that insurance companies look for: neck and back pain, grooving from bra straps, rashes if they have them. A lot of insurance companies now are asking that there's documentation they've tried other things, whether that's seeing a chiropractor, going to PT, or taking over-the-counter medications such as Tylenol or NSAIDs. And so the more that's documented, the better. It makes my notes stronger. So I had one more recently that actually I had documented that stuff in my note, and the insurance company like insisted that the primary care also document that. And luckily the primary care physician here was really amazing and very quickly called the patient, asked all the questions, put it in their note, and we got it approved. And it was like a very seamless process. But those, if you can put those things when you're seeing these patients, you know, the young women coming to you, that you're going to send them to me, it just helps. It's not always necessary, but it is helpful. And I do really enjoy doing those. So I welcome the consultations, and I'm very appreciative of the ones I've received.
And how do you determine whether it's going to be, besides the pain and how long they've had the pain, is there any other markers that we could be thinking about in our office before we send them your way, besides the skin stuff that you mentioned already?
Yeah, honestly, I think that if someone's complaining about it to you, it's worth sending them,
Yeah.
because even sometimes insurance companies don't cover it, but for some patients it bothers them enough that like it is consider you can do a cosmetic reduction. I try to avoid that. I will fight insurance companies tooth and nail to get it covered, but if it really bothers the patient, then it's worth at least a discussion. Because what I find interesting is that sometimes it's not even the weight. And the literature shows it doesn't matter how much weight you remove, their symptoms will improve. And I think a lot of that is because it's a dynamic thing. So some women just have very low set breasts that sag. And as you can imagine, that's going to pull you down. That's going to cause that neck and back pain. So just by doing a small reduction, but lifting them up and putting them into a more anatomic position, I think can really help with symptoms. And while that might not be covered by insurance, it can be very beneficial and make patients feel a lot better. The other thing that can help sometimes is the psychological impact of it, especially in younger women. You know, they're uncomfortable in their clothes, they have a hard time finding them, they feel uncomfortable at school. That can really help. And I'm not opposed to doing this surgery on young women, you know, 15, 16, as long as they have been stable in their size for at least a year. And then I really go into the risks with their moms or their parents or their caregiver and them, because it does have long-term consequences. We're not 100% sure how much of an effect it has on the ability to breastfeed. And so I think counseling them on that is really important, because when you're young, you're not thinking about that. But I would hate to contribute to something that down the road causes them distress.
Great. Thanks, Ellie.
Yeah.
Okay, well, we're coming up on the top of the hour. Really appreciate you coming by and everyone logging on. There is a question about the CME code. So we are, these talks are good for category 2 codes, which are essentially self-study. So you don't need to submit a code, and that's based on the self-study there. The rest of our talks are all archived. Folks, just to update, one other quick announcement. Some people heard that this morning, I'm sure. We are now giving vaccines at our TripAdvisor site to 12 to 15-year-olds. Any pediatric provider, family doc, or nurse practitioner can order that. No tickets are needed. Please feel free to kind of order that and get your kids in your practice and your kids in your families all immunized. So please feel free to use that. Of course, we are also now offering walk-in slots at our TripAdvisor site. So if you get someone in your office who's ready to sign up, send them around and eat them as long as we're open. So again, we're trying to get as many people vaccinated so we can get back to some normalcy here. So we appreciate that. I hope everyone has a terrific weekend. It's going to be a beautiful one. And we'll see you all next week for inguinal pain. Thanks, Ellie. Bye.